Let's finish up the cardiovascular system by talking about congestive heart failure, the cardiac cycle, and the intrinsic cardiac conduction system. So congestive heart failure, CHF. It is so called because oftentimes blood will back up into the lungs and cause people to feel as though they have congestion. So the idea that blood is backing up gives you the idea of exactly what's happening here. Basically, the blood cannot any longer be pumped by the heart. The heart is having a hard time pumping for various reasons, which we will discuss. And since the blood cannot be pumped out, it starts to back up. But of course, the resultant issue here is not the blood backing up into the lungs. Rather, it's the idea that the cardiac output is not high enough. So we start off with just a reminder that our cardiac output should be about 5 liters per minute. I put a box around that once again. It's such an important number. It's something we can come back to again and again and sort of compare different situations, and this will come up several times in the future. So it's a good idea just to remember cardiac output, 5 liters per minute, the amount of blood pumped by your heart every minute. So the situation with congestive heart failure is that the cardiac output is too low. It's so low that it can no longer, in the late stages of CHF, it's so low that you can no longer actually meet the needs of the tissues of the body. You can't get the blood down to the tips of your toes and the tips of your fingers and the liver and the kidneys, and therefore your organs cannot function anymore under these conditions. Now, we are going to bring up one more set of numbers. It's a good one to remember, though, because although we talk about stroke volume in the classroom, ejection fraction is usually how this is measured in a clinic. So ejection fraction, or EF, is where you take your stroke volume, the amount of blood that's squeezed out of the heart with each heartbeat, and you divide it by your EDV, the end diastolic volume, which is the amount of blood that is filling the heart during the rest period, during diastole. So the EDV is always the largest number because it's the largest amount of blood possible in your heart. Okay, so we take our numbers then, our typical numbers for both of these. We have 70 milliliters per beat for our stroke volume. We have 120 milliliters per beat for the EDV. And that divided out comes to 0.58 or 58% or so. And this is a healthy number. These are the typical numbers that we use to demonstrate this. And yeah, it's healthy because the healthy range for your ejection fraction is between 50 and 75%. A borderline number would be between 40 and 49%. But the way that we actually diagnose congestive heart failure is we take this ejection fraction and then we see if it's a little bit too low. So I've seen different numbers on this, but the consensus is below 39% or below 40% would be diagnosed as congestive heart failure and therefore warrants some kind of treatment or looking into exactly what's going on with the heart. So what's going on with the heart? What kind of scenarios might we have where a person might succumb to congestive heart failure, be diagnosed with congestive heart failure? We're going to draw a little heart here and an aorta at the top there. I'm going to draw the coronary vessels with the idea that the coronary vessels branch directly out of the aorta. The coronary vessels are structures that they basically go from the aorta and they strap down the outside of the heart and then they dive back into the heart in order to feed the myocardium. Now these vessels are tiny, which is one of the reasons they give us so much trouble. First of all, the muscles of the heart are incredibly thirsty for oxygen and nutrients and all the rest of this stuff. And so they are absolutely demanding a good solid blood supply, but also the coronary vessels are tiny. And so if you have any kind of an issue there, for example, a little bit of fat buildup in your blood, LDLs or triglycerides, and that's why we measure those numbers when we do a CBC, we really look at those kind of numbers. A large amount of fat in your blood could potentially block, or if you have, for example, a plaque that was blocking one of these vessels, then it might actually inhibit the feeding of the myocardium. You can no longer get a blood supply there. And there's various treatments for this, of course, an angioplasty and a stent placement, or a bypass surgery if you're not eligible for an angioplasty. For example, if your coronary vessels are a little bit too delicate or calcified over time. This condition is called coronary atherosclerosis, and if it is left untreated, then it could lead to some issues down the line. And so oftentimes we'll talk about coronary atherosclerosis combined together with damage to the heart, which it could often lead to ischemia. So ischemia is a general term that means a lack of oxygen supply to a tissue of your body. This in turn, through a series of issues, such as heart tissue having to resort to glycolysis, for example, could lead to multiple myocardial infarcts. Now, the term infarct is a general term that means tissue damage. So multiple myocardial infarcts is basically multiple sites of damage to the walls of the heart. And oftentimes a multiple MI or an MMI is used to describe a heart attack. But this would be a late stage congestive heart failure issue. And it's basically a degenerative issue. Over time, it gets worse and worse. Now, another way that we might experience congestive heart failure is when we have persistent high blood pressure. So the visual on this is we're usually paying attention to that left ventricle. The left ventricle is trying to push blood into the aorta. But if it turns out that there is high blood pressure in the aorta, basically in the arterial system of your body, then it's harder for the left ventricle over time to keep pushing against this. Everybody experiences some level of high blood pressure, for example, under stressful situations or when exercising, but we're talking about a long-term issue with very high blood pressure. Now, over time, this could put so much strain on the walls of the heart that, again, you could end up with multiple myocardial infarcts because the heart simply cannot keep pushing under these conditions. It's demanding more and more oxygen out of the blood supply, out of those coronary vessels, and sometimes these things can actually be tied together. So again, ischemia, multiple myocardial infarct. For our last, I think that the last example of congestive heart failure is the one that's a little bit more confusing. So I'm going to show on the left-hand side here, I'm showing a heart that has a nice, healthy, robust myocardium, thick walls, good amount of cells that are robust and still functioning properly, and ventricles that are relatively small. So what we're describing here on the right-hand side is dilated cardiomyopathy. Dilated cardiomyopathy is a situation where your ventricles actually get to be quite large, partially because it could be because you were an athlete at one time and your ventricles got large as a result of that, of having a really efficient, healthy heart. But it could also be that the walls themselves have started degrading over time. So dilated cardiomyopathy is a little bit confusing because the ventricles are quite large, which means that you could potentially have a high EDV, an end diastolic volume. But at the same time, the walls are so degraded that the contractility is quite off. So in the early stages of dilated cardiomyopathy, there actually could be a balance between a high EDV and a high ESV that would actually kind of cancel each other out, and your stroke volume would actually still be substantial. But in the late stages of dilated cardiomyopathy, definitely the contractility issue would start to take over, and your stroke volume would start to really suffer under these conditions. And of course, if your stroke volume is suffering, your cardiac output would suffer as well. All right, so let's move on to our next topic here. We're going to be turning from looking specifically at the myocardium, and we're going to focus in on the electrical system of the heart. But in order to focus in on this, we're going to basically tell this same story three different ways. At the top, we're going to talk about the three different stages of the cardiac cycle. The first of the stages is called early diastole. We've talked about diastole being the resting stage of the heart, but it turns out there's two phases to this. Early diastole and then mid to late diastole, there's different events that are occurring. So it's not like rest, there's nothing happening. There's actually quite a lot happening over time. And then lastly, the last stage of the cardiac cycle is systole, which is the contraction of the heart. So in early diastole, the chief thing that's happening is that the heart is receiving blood, and it's basically filling up. The blood comes into the right atrium from the vena cava and into the left atrium from the pulmonary veins, from the lungs. And then that blood is mostly sent, about 80% of the blood is sent directly down into the ventricles without any real effort. So this is passive filling of blood. About 80% of your blood makes its way into the ventricles in this way. But that last 20%, or as much as possible, still needs to be pushed down into the ventricles for as much efficient ability to push out blood eventually as possible. So In mid to late diastole, the atria actually contract and push blood down into the ventricles. So mid to late diastole, it's quite important. A lot of times we skip over this step. The atria do have muscles and they do contract, and so the atria are contracting during mid to late diastole. Lastly, our final stage of the cardiac cycle is systole, and what happens during systole is that the ventricles contract. The tricuspid and bicuspid valves will be closed at this stage to ensure that blood is not making its way back into the atria. So instead, the right ventricle will be pushing blood out through the pulmonary trunk. The left ventricle will be pushing blood out through the aorta. And so there's a series of things that happens, but the basic central point here is that the ventricles are contracting. The ventricles contract during ventricular systole. Now, to put a fine point on this, so we just want to tie all these lessons together. Your end diastolic volume will be achieved at the end of mid to late diastole, and your end systolic volume will be achieved at the end of systole. Now we turn to the intrinsic cardiac conduction system, and this is the electrical impulses that run through the heart and cause that specific sequence that I discussed up above there. The cardiac cycle is a specific sequence of muscle contractions that must always happen exactly that way. You have to have a rest while the heart fills, you have to have the atria contract, and then you have to have the ventricles contract. If we keep those three basic principles in mind, that sequence of what has to happen, it'll be a little easier to make our way through what's happening with the intrinsic cardiac conduction system. So the first two structures that we're going to be labeling here are the SA node, the sinoatrial node, which is the natural pacemaker of the heart, and the AV node, the atrioventricular node. Both of these are groups of cells that are found in the wall of the right atrium. And then from there, we're going to continue to draw some branches that go from there and kind of make their way through the ventricles. The first one we're going to label is the AV bundle, the atrioventricular bundle. And then we have the bundle branches. So the AV bundle will branch into at least two parts. And then you have bundle branches. Both of these are going to be running through the interventricular septum. And then as we penetrate through the apex at the very bottom, according to our picture of our heart, we have a whole series of branches that make up the subendocardial conduction network. And the subendocardial conduction network is responsible not only for basically penetrating all through those very thick and important walls of the ventricles, but also bringing fibers up into the papillary muscles in the floors of the ventricles that in turn allow for that closure, all-important closure of the bicuspid and tricuspid valve, which again prevents that backflow back into the atria. All right, so it turns out that all of these purple structures that I am drawing here are basically a line of autorhythmic cells, which, keep in mind, the autorhythmic cells have that pacemaker potential. They are self-pacing cells. It turns out the SA nodes are the fastest pacers, and so therefore they are the ones that actually generate the first and most important of the signals here, and everything else follows suit. The SA node would generate impulses about 100 times per minute, but they are slowed down by the parasympathetic nervous system at rest to about 70, or 70 beats per minute is a typical heart rate because of that innervation by the autonomic nervous system. Now, the SA node is the natural pacemaker because it depolarizes the most times per minute, about 100. But if something happened to the SA node, it was no longer in charge. The AV node would take over, which depolarizes about 50 times per minute. So both structures can actually act as pacemakers. And in fact, all of the autorhythmic cells have their own, they all generate pacemaker potentials just at different rates. It just so happens that the SA node is the fastest at about 100, so it always sets the pace. Unless something detrimental happens to the heart, the SA node is the natural pacemaker. You'll notice that I am drawing green arrows coming from the SA node and extending through both sides of the atrium, both the left atrium and the right atrium. These are different types of electrical signals that I want to talk about for a moment. The types of cells that are generating these signals are the cardiac contractile cells, those contractile cells that are 99% of the makeup of the heart. So remember from way back that the autorhythmic cells are only about 1% of the cells in the heart, but the contractile cells, as you would imagine, because the heart is a big muscle, make up 99% of the myocardium. So the greatest amount of electrical potential that we are able to understand about the heart is going to be generated actually by the contractile muscle cells. So what happens is, of course, we went over this in the last video. We talk about how you have to have an electrical potential first that then is followed by a contraction. And so the electrical potential is called a plateau potential, and it's pretty significant. Now, the whole atrium, the left and right atrium, that base of the heart up there at the top, according to our understanding of the heart, the whole thing is basically one functional syncytium. Remember, there are gap junctions between the cells. This allows the cardiac muscle fibers to basically work as one large functional cell, that everything can happen very simultaneously. Everything can happen quickly along the length of these cells because they basically function like one big cell. So these electrical potentials generated by the SA node in the first place are very quickly passed from cell to cell to cell, and the entire atrium at once is able to experience that potential. So if we go back up to the top of the page, remember that what's happening here is that we are allowing all of those muscles to contract at one time, all at once, very simultaneously, which allows us to have that atrial contraction during mid to late diastole. And so again, we have this plateau potential that is followed by a muscle contraction. So the end result is we see the muscle contraction, but you must understand that what happens first is there is an electrical signal that is generated that precedes that muscle contraction. So in this mood, we are going to take a look at our EKG or our ECG, our electrocardiogram. So it's a pretty standard lesson, the P wave, a small bump, followed by a QRS complex that's pretty substantial and noticeable, followed by a slightly larger bump called the T wave. The easy way to describe this is that the P wave represents a depolarization of the atria. But I want to go a little further than that and say, well, actually, it's the depolarization of the plateau potentials, specifically of the cardiac contractile muscle cells themselves. And this precedes or is followed by the atrial contraction. So we can imply that if the P wave is, timed correctly and everything is going well, then we can imply that yes, the atria are probably functioning properly and contracting when they're supposed to and with the timing they're supposed to and so on. But it's preceded by those plateau potentials, and that is what we actually see on the P wave. The beauty of an EKG is that we can gauge the health of the heart using electrodes attached to the skin. We don't have to crack open the rib cage and take a look at the heart. We can literally place electrodes on the outside of our body and still understand what's going on inside of the heart because these electrical signals are so profound. Well, what makes them profound is that we have all of these 99% of these contractile muscle fibers that are experiencing this plateau potential pretty much all at the same time, and that's what causes that little bump that makes its way all the way again to the surface of our skin because it's so substantial. So the plateau potentials of the contractile muscle fibers are the thing that generates that P wave in the first place. And then you can follow this to say, well, the QRS complex is the depolarization of the ventricles, but specifically, again, it is the plateau potentials that are it's the depolarization of the plateau potentials that are making their way through all of those 99% of the myocardium contractile muscle fibers. That's those plateau potentials that are so significant that they're actually able to be felt on the outside of the body. So the plateau potentials of the ventricles followed, of course, by the contraction of those contractile muscle filaments, those contractile muscle fibers that make up the myocardium of the ventricles. So the P wave represents the contraction of the atrium, but what you're really measuring are the plateau potentials of the muscle fibers. And again, the contraction of the ventricles are represented by the QRS and then the T, but what they're really gauging are the plateau potentials running through those cells in the first place and then followed by the muscle contraction. I want to reiterate and just point to this, the tie-in between these three figures. The P wave corresponds with the plateau potentials that are shown in green in the intrinsic cardiac conduction diagram, which corresponds with mid to late diastole, which shows the contraction of the actual atria up above. So the P wave is the plateau potentials that then later lead to the contraction of the atrium. And to complete the story, of course, we have to discuss the ventricles. So in purple, again, we have the autorhythmic cells, all the different autorhythmic cells that make their way through the myocardium of the ventricles, the atrium and the ventricles. But in this case, we're going to be talking about, in green, we're going to be drawing those plateau potentials that are generated by the muscle fibers that are surrounding all of these autorhythmic cells. So yes, the intrinsic cardiac conduction system is autorhythmic cells, but they generate an impulse that is then spread to the neighboring muscle fibers. And again, they generate these QRS complex and the T wave, the repolarization, the depolarization and the repolarization of that plateau potential that then in turn leads to the muscle contraction of the ventricles. So the QRS complex and the T wave represent the plateau potentials that then are followed with a little bit of a delay, just a slight few millisecond delay, maybe 20 to 50 millisecond delay with the contraction of the ventricles. So QRST, they are plateau potentials making their way through the ventricles that then are followed by the contraction of the ventricles. Let's take a look at some anomalies of the heart that can be diagnosed by reading an EKG. So the first one we're going to draw is called a junctional rhythm. What you'll see in a junctional rhythm is that you'll see the distinctive QRS and the T, which represents the idea that you still have electrical impulses going through the ventricles. However, what's missing here is the P wave, which indicates there are no electrical impulses making their way through the atrium, and it's very likely that the SA node itself is no longer generating impulses for whatever reason, possibly tissue damage. So what happens in this case is that the AV node actually takes over and begins its own rhythm. Remember that the AV node, as is true of all autorhythmic cells, do generate their own pacemaker potentials. So the heart rate would change and you would no longer have the advantage of mid to late diastole where the atria are actually squeezing that residual blood downward into the ventricles. It's not an efficient way to conduct heart impulses. This person probably would require, at this point, they would need a pacemaker in order to get everything functioning correctly again. But at the moment, this person does not have a functional atrium. No P waves, no atrial contraction. The next one we're going to take a look at is called VFib, or ventricular fibrillation. We start off with what looks to be somewhat of a functional sequential heart rate, and then it is followed by basically nonsense. There's no rhythm here. There's no sequence. The heart would be fibrillating, or it would be kind of just wiggling back and forth in a pretty useless way rather than that nice atrial contraction followed by ventricular contraction. It would have no sequence at all. VFib is a very serious business. Ventricular fibrillation, you basically can't survive it unless you somehow reset the heart rhythm, which is what a defibrillator is for. Lastly, we're going to talk about heart block. Heart block is actually kind of a complicated topic because there's several different types of heart block. You can really get lost in the weeds of this whole thing. So we're just going to be discussing the most profound and the easiest to recognize type of heart block, which would be complete heart block. So for this, we have to discuss one more thing that we didn't add to the intrinsic cardiac conduction system, which is the idea that the SA node has to be able to generate a signal going to the AV node. Remember, the SA node is the natural pacemaker, and it needs to be able to send a signal not just out to the atria through those plateau potentials, but directly to the AV node. And in order to do this, it's going to be doing so with a little bit of a delay. That delay is significant and important. It's about 100 milliseconds. So I'm just going to replicate it down here so that we can take a closer look because it's kind of squinched in there. It's really, really important. So the SA node talks to the AV node with a little bit of a delay, and that's what's supposed to happen. But with heart block, what happens is there's some kind of an issue where that bridge of communication is no longer happening properly for whatever reason. And sometimes it's due to, for example, heart damage that is occurring somewhere in between those two structures. Or an electrical signal is just going askew. Something is happening between them. So with complete heart block, which is what I'm drawing here, the SA node and the AB node are really struggling to communicate with each other. Basically, you have P wave after P wave after P wave, which are not always followed by a QRS complex. You can have 3 or 4 or 5 P waves in a row. And then finally, in this case, we do have a QRS complex and then a couple more P waves. So remember what the P wave represents. It represents the electrical signals moving through the atria, which are followed by atrial contraction. When we do not have QRS complexes, we are not allowing for the generation of electrical signals through the ventricles, and therefore the ventricles are not contracting. This is an unsustainable situation which would definitely be fatal and relatively quickly. You have to have ventricular contraction. The left ventricle is the most important chamber of the heart by far, because if the left ventricle is not functioning correctly, you are not squeezing blood out to all the tissues of your body. So complete heart block, and really any kind of heart block, must be remedied or it will be a fatality.